Our next presentation is Peter Bennett from Sydney School of Veterinary Science. I hope I've got that right, Peter, if I dumped you in it. He's going to talk about antimicrobial use in companion animals during chemotherapy. Peter.
All right. Thank you, Mark. And thank you, everyone. So with this, the reason behind this retrospective analysis is really some discussions I had with Jackie Norris and the fact that there are currently no guidelines for antimicrobial use in veterinary chemotherapy patients. There's one paper that presents some recommendations, but a number of oncologists recommend routine prophylactic use of antimicrobials in cancer patients. There has been an identified decrease in risk of adverse events with the use of antimicrobials, but blanket use has not been shown to be necessary, nor what type of antibiotics. So the idea was, with the increasing use in general practice, is to see what is currently being used and are there any areas of concern that would increase the impetus to have some guidelines. So we searched Sophie searched the VetCompass database for any chemotherapy drugs. We looked through the records, and where chemotherapy was administered, then looked at whether there was antimicrobial use during the time of chemotherapy, and included such things as the antibiotic use, the duration of use, and the indications that were listed for its use. So what I'm going to present today is a partial result, because we've everything ground to a halt with COVID. But this is looking at the records from 177 individual patients who received chemotherapy. And of these, 44, nearly 25% had no record of antimicrobial use, but that indicates that 75% did have antimicrobial use during chemotherapy. And of the 133 cases that did receive antimicrobials were dispensed 533 times. There was a range of tumor types, predominantly lymphoma under hematopoietic. There was reasonably consistent antibiotic use. Those numbers there indicate when antibiotics were not used. The unknown tumor type had relatively poor records. There was indications that chemotherapy was given and antimicrobials in one case, but that number may be because of just lack of information. When looking at individual patients, so they receive between 1 and 25 courses of antibiotics during their chemotherapy. And each patient received between 1 and 5 different antibiotics, and sometimes sequentially, and sometimes 2 to 3 antibiotics were given concurrently. In this presentation, I haven't got time to sort of separate all of that out, and I want to complete the data set before going into that depth. This is the list of antimicrobials we used and the numbers of times that they were dispensed. The most common, and this fits with what Laura indicated, was potentiated amoxicillin as being the most common. Trimethoprim sulfur was the second, and that probably relates to an older paper that indicated that trimethoprim sulfur drugs had less impact on the normal flora or gastrointestinal flora in patients receiving chemotherapy. But there was a fairly high numbers of prescriptions for enrofloxacin and also cefazocin. When we look at the duration of use, it ranged from 1 day to 120 days of continuous antimicrobial use, with a mean of 16 and a median of 11 days. I had a quick look at the different antimicrobials, if there was any difference, and they were all reasonably consistent. Some, such as gentamicin and marbafloxacin, had very small numbers of use. So those numbers may not be truly indicative of what would be used. Then looking at the reasons, so fever was an indication in 20 patients, but when looking at the records, about half of them had a temperature indicated at 39.5 or less, so potentially not a true fever. Neutropenia was the indication 81 times, with about half of them for grade 1 and grade 2 neutropenia, which is neutrophil counts of greater than 1, and gastroenteritis in 52 cases, covering sort of anorexia, diarrhea, and vomiting. And there were some patients where there were multiple reasons, but the primary one indicated in the record is what I'm reporting here. Prophylaxis, so just we're starting a chemotherapy drug, so we're going to place the patient on antibiotics, was the most common at 237 times. It was unclear from the record, 52 times, so they were dispensed. They weren't clearly related to previous neutropenia or anything else, but they didn't also state that they were prophylactic, or it wasn't clear and they weren't concurrent. And a number had other reasons, such as otitis or dermatitis. And in 5 times, neutrophilia was the cited reason. What do we know in people? High risk of febrile neutropenia is the main reason for prescribing antimicrobials, or risk of profound protracted neutropenia with the definition listed. And in veterinary patients, most of them are extracted from human guidelines due to the paucity of veterinary studies, and the only paper that makes a recommendation said we need better evidence. They made some recommendations, so use indicated with a neutrophil count of less than 0.75, but that's based on their hospital practice, that number, and a subsequent study where they showed that that seemed to be beneficial for an anticipated neutrophil nadir. And if they've got concurrent problems, that increases the risk. And not to use it when the neutrophil count was greater than 1, but mainly on fairly low levels of evidence. So antimicrobial use is common in patients in chemotherapy, as we anticipated. Prophylaxis is the most common reason, but there's a broad spectrum of antimicrobials used. The duration seems excessive, and we need to complete analysis of the data to make sure that there's not one hospital skewing the data. But we need more information, and we do need some guidelines to better treat our patients who receive chemotherapy. And thank you all. And with that, I will answer any questions if there are any.
Thank you, Peter. Fantastic. Are there any questions for Peter? I've got a small one to begin us while we're waiting for people to think about questions. You mentioned that probably lymphoma is the tumour type that incurs antibiotic usage the most. Do you think that's because it's the most commonly diagnosed tumour, or do you think that the chemotherapeutic protocols are more likely to result in neutropenia, or what do you think is underlying that?
Again, the human experience is that hematopoietic tumors are more likely to develop neutropenia than other tumors, and they're more likely to get a combination protocol. Now, in people, it's much more aggressive than what we use, but that would be the main reasons. And there is evidence in our patients that the same applies, that combination protocols and hematopoietic tumors.
Great, thank you. Any other questions for Peter? Anne, did I see you wanting to say something?
Hey, you're on mute, Anne.
Yeah, no, I couldn't find myself. My little picture had disappeared. It was behind the chat sign. I was trying furiously to remember who it was that wrote a relatively recent paper, Peter, that had some commentary on this, and I was wondering what your comments would be. It was a comparison of the 0.75 recommendation and a 0.5 recommendation for neutrophil counts as triggers for starting not chemotherapy, antibiotic prophylactic therapy.
I think it's one where the business study that had the 0.75 was based on, that's what they did in the hospital. So their study didn't actually look at 0.5. So
right, but there was a more recent paper.
There is
that
another
did
one that says that 0.5, which is the human level, is potentially more realistic. But we also have a marked difference in our patients in I suppose, microbial risk in our patients compared to human patients as well. So level of hygiene is different. So whether that's a factor, but I think we really need more information. And I hope this sort of says that antimicrobial use, particularly for quinolones and cefazolin, probably clues that we need to come up with when do we really need to use them and what should we use. At least trimethoprim sulfur is pretty commonly used.
Right. Thank you. Yes. So yes. Thanks, Peter. Fantastic talk. Thank you very much.